Dr.
Hi,
Dombo.
how are you? Oh,
I'm well. I'm really glad to see you. Thank you for joining us again for another Instagram Live. Just to let you all know at the start of this conversation that Dr. Dombo will be joining us for a webinar coming up next month. Is it that we have it scheduled? Yeah. So I'm really looking forward to that, and I know so many of you are as well. Today, we're sort of closing out Menopause Awareness Month, talking about the myths of menopause. There are some that are very commonly known. There are others that are known among in different camps of the menopause conversation, if you will. And we're going to unpack some of those. I will be looking for your questions. I just saw somebody, it looked like a lot of words under someone's name. So I will go back and, oh, it looks like we may have lost Dr. Dombo. I will go back and get into get into your, oh, I love this question. We already have a great question. Can menopause be the cause of your itching? While Dr. Dombo rejoins, I will let you know that yes, indeed, itchy skin, itchy ears, itchy eyes, dry mouth, itchy skin both on your face, on your body is an extremely common symptom of perimenopause. Here, Dr. Dombo is joining us again. So yes, I won't call out who that was, but hi, Dr. Dombo. We lost you for a second. I don't know if you heard someone just happened to ask, is itchy skin a symptom of menopause or perimenopause? I did go ahead and answer that while you reconnected, but let's get into the myths of menopause. The first question I have for you, um, many believe that menopause is sudden. I think there's sort of almost like a language that we use about it that can be confusing to some people, but it is in fact a gradual transition. Can you school us on
yeah,
that?
absolutely.
Debunk that myth, as it were.
So, just to look at like maybe some definitions to start out with, right? So, I think a lot of us already know menopause. We define that as 12 months without 12 months without menstrual period, right? And that's kind of how we define like, okay, you are like you have reached menopause, and that's a definition to help us know, okay, if you're postmenopausal and you're having symptoms, if you're premenopausal, perimenopausal, and you're having symptoms, kind of how do we go about and, bleeding patterns and all that. So it really just helps us from a medical standpoint to kind of gauge where your body is. But it's a very gradual transition, right? So we know that with the normal menstrual cycle, you have like, your estradiol goes up the first half of the cycle and then it comes down. And then the second half of your cycle, progesterone goes up. But what tends to happen as your ovaries, like as the number of, you have what's called atresia, like follicular atresia. And so what happens is you have this very erratic pattern, not a very normal cycle, but an erratic pattern of estrogen secretion ovaries that can happen up to 10 years before that last menstrual period. So when you're going through that pattern, like ups and downs and hormonal fluctuations, you can have some really high highs, but then you can also have some really low lows. And when you have those lows is when you start to experience some of the symptoms that are associated with menopause that can or cannot be accompanied by irregular periods or changes in your cycle. Um, However, that erraticness gradually leads to a decline, and your ovaries start to really decline around that time. So 12 months after your period, you may still produce small amounts of estrogen, even that, but it's very, very small.
Terrific.
So it's just a decline of estrogen secretion.
Thank you. That is myth number one. Debunked. Menopause is not sudden. Menopause always starts at 50. I think, again, the sort of language that we're all working on changing in real time over the last few years, that this menopause conversation has gotten bigger and louder. There's certainly been this 50 as some sort of a marker Tell us about that.
I mean, I think in general, when you think about turning 50, there's so much that comes with that. Like, oh my gosh, 50, is this mean that I'm, getting old? Like but average age of menopause in the United States is 51, right? So, but then there's so many cultural, genetic, you know, factors that come into play. So let's say African American women have been found to go through menopause 2 years on average before complications. You look at women of Southeast Asian descent, that also can play into your experience. If you're Latina, more like 1 year, that age of 51. So I think when we look at numbers, we're looking at it based on data, and we have the data for the United States. So here in the US, like the average age of menopause is 1, but it can, like, I think genetics is huge. That's why I always tell my patients, like, ask your mom, find out, when your mom went through menopause. Because for you, more than likely, if you're trying to make a decision about, oh my gosh, I'm having these really heavy periods, do I need to have a hysterectomy? We can kind of gauge based on when your last menstrual period will be, based on like when your mom's last menstrual period will be. It's not exact science, but it gives us some level of an idea much longer, may you
Yeah.
go, with these irregular bleeding patterns that may be really bothersome. Do you get an IUD? Do you want it done completely? Like, there's so many things that go into play, when we're looking at that average age.
Great. Thank you so much. Hot flashes are the only symptom. That is menopause myth number 3.
Yeah, so it's really interesting because when you look at the breakdown based on race, and how, what are the most common symptoms that women present with, um, hot flashes may be one. I think in African American women, that is more predominantly where you see hot flashes. There are other symptoms like, mood symptoms where you find that you're depressed, you're unable to manage stress, irritability, like symptoms where you're just anxious and you just cannot overcome this anxiety that you're living with day to day. Those are some ways that it may present, and without any hot flashes at all.
Yeah.
So it's really important that every person realize that it can present differently. I mean, some people may just present with dry skin, dry eyes. Like, that may be the most prominent symptom that you may experience, but it doesn't necessarily mean that, oh, you didn't have any issues, going through
Right.
menopause. You didn't have hot flashes. So I think it's
Thank you.
important that, or, after age 45, is like start noticing changes. It's important to just discuss, obviously with your primary care physician or your OBGYN, hey, I'm having these symptoms and they seem to be becoming more prominent. Could this be related, to
Yeah.
menopause? May not be, but it's not, a one size fits all for every single person.
I so appreciate that. And just bear with me while I deviate for a minute, but you're making me think about something I talk about in our support groups a lot, which is to document your symptoms. This is hard to do when life is going and coming at us fast, or we have a lot of obligations. We may not be thinking to do it, which is the exact reason I encourage women to jot down in your phone or in a book or on a sticky note how you're doing, kind of how are things manifesting for you. Certainly by the time you're in your early 40s, you may be feeling things and not necessarily connecting the dots between perimenopause, menopause, and your age, for example. And if you have this idea that 50 is somehow this marker, when you're feeling anxiety or when you're feeling, as you mentioned, mood issues are coming up, you may not be thinking, and there's 100 reasons why anxiety could be ramped up, or you might be feeling particularly blue or something like that. But again, if you just jot stuff down, it helps you, and it helps you be um, ready for what might be a short doctor appointment. And it helps you kind of flush things out, I think, right, with your practitioner.
And this is what I also, because I know that even in perimenopause, a lot of women start complaining of the symptoms happening the 2 weeks before their cycle, right?
Mm.
They know migraines 2 weeks before, like they never had migraines. And that could be because of the decline of estradiol, and having something like an estradiol patch during, like may really alleviate that. So just make sure when you document everything, kind of also correlate it to where you are in the cycle, because I think it's really
Mm.
important. And you go to speak to a doctor, especially like an OBGYN, you want to be able to be clear with them. Hey, I'm noticing these symptoms, and these symptoms happen to be occurring consistently, like at this point in my cycle, or they're happening all the time. That just gives them a little bit more help
Yeah.
to kind of tease apart where this could be coming from.
You made me think of one other thing really important, which is speaking to a menopause practitioner. So you are an OBGYN, but you're also a menopause specialist, and you had to go back and get that specific education so that you could better treat those patients who were
Yeah.
going through it. But also you said something important I caught, which is your hormones may be fluctuating, and so you might be serviced with a patch. And I think that might not also resonate for people, that when you are in perimenopause or when you are determined to be suffering with any number of symptoms that are untenable to you, that may be a time that you want to consider menopause hormonal treatment.
Well, I think it's worth discussing, because if it's not the patch, maybe if it's really mood symptoms that you're experiencing, it could be just, bioidentical progesterone,
Right.
right? That, and I always say, and I always tell patients, because I think there's this idea that, oh my gosh, like, am I ready? Should I be on it? I don't know if there's always a chance of at least just doing a 3-month trial, right? Because for me, and that was my biggest thing, I just gave myself a month. I said, okay, I'm going to determine if this thing really works, or it
Yeah.
really, because truly, if you just, give something a month or 3 months, a short period of time as a trial, and you feel absolutely no difference or absolutely no change, it could mean one of two things, right? It could mean, number one, that may not need right now, or number two, you just may need to taper it to a high dose. So I think at least if you notice that there is some improvement, that may be something that may be
That's
beneficial for you.
super helpful. Thank you for that, Dr. Dombo. Okay, I'm moving on. Myth number 4, menopause ends all sexual desire.
That's really interesting, because I think the question that, and there's a lot of reframing, right, around like sex drive, libido, that comes into that conversation. And I think it's so important to determine the root cause. Like, what is it? Is there something that happens to you specifically that may be the result? Is it because you're having vaginal dryness, that is causing pain with intercourse, or you've heard somebody talk about it, right? That they just don't want to have sex anymore, but you don't know the reason why. Again, it could be so many different factors, right? It could be relational issues,
Sure.
that are, in your life, where there's, parent issues that you're trying to deal with, and that's causing stress and conflict in your relationship. Or could there be stress that's happening right now with your children? There's so many different factors, but the truth of the matter is that that does not necessarily have to be true. And if you're experiencing it, I think it's so important to discuss it with a provider, because they can, or at least a clinician, let me put it in those words, because they can actually go through, if that is an issue for you, what are some things that we can do? And not everything is rocket science, where it's like, oh my gosh, we have to come up with this elaborate plan. It could literally be, okay, let's look at your schedule. When can the two of you guys, create some time for the
Yep.
two of you, and, be able to look at creating intimacy, right? So,
Right.
so there's many different ways to look at it. And so it's a big topic, but with so many smaller different things to consider when you look at that.
Great.
So no,
Thank you.
to answer the question, the answer is no, and it can be a time of a lot of like liberation,
Yes.
sexually.
Oh, thank you.
Yeah.
Um, the big one, hormone replacement therapy or MHT is dangerous. Myth number 5.
So the answer to that is no. And I understand why it is considered that way. So I did my residency training in 2001 to 2005, and the Women's Health Initiative was stopped in 2002. And I remember being taught that hormone replacement therapy, or menopause hormone therapy, as we now know it, is can cause breast cancer,
Mm-hmm.
right? And so I remember at that time making a decision that, oh, that's definitely the
Never
last
going to use it. Yeah.
I felt like it was dangerous to my patients. And I think that myth is something that is being the last couple of years, there's really a lot of evidence that showed that is a myth that we are debunking. I think it's important to remember that there are a lot of like doctors, nurse practitioners, like people who are care to women during, who still may not have updated themselves with information, and looking at, a breakdown of the statistics and the studies as to why that became a myth. And with the WHI, the average age of women was 60 to 70. So right now it's a more nuanced way of looking at how do we take care of women with, with hormone therapy at the best time it is to introduce, that in their lives. The early menopause has the benefits far outweigh the
Right.
risks. So it's so important to remember that not everybody has come to a place where they have done the due diligence of looking at the data, more specifically, and that may be something you hear, or that may be a residual. And when there's fear, there's going to be,
Sure.
like, move forward with something. So you have to educate yourself.
Is there a particular piece, you talked about breast cancer, but is there within that, or sort of under that breast cancer umbrella mythology, that is a kind of a thread to pull and maybe expand on a little bit more for clarity's sake? So, for example, correct me if I'm wrong or move on to something else, but for example, if my mother had breast cancer, I am not a candidate for MHT. That's a
Right.
big one. It's a common one. It's helped kind of,
Yeah.
you know,
Yeah. Yeah. So that's
go ahead.
another,
Sorry.
because it's true, right? So I think it's important to remember that, again, anything breast cancer related is going to be like, no, So having a family history of breast cancer is not a contraindication to taking hormone therapy. And a lot of women who also have had testing for the BRCA gene, and even if they are BRCA gene positive, again, that is not a contraindication, for taking hormone therapy. I think you just have to find somebody who can provide it to you, safely.
Right.
A lot of people who are BRCA positive have already had either a mastectomy or oophorectomy. And in that situation, again, very, very safe to prescribe hormone therapy. And, the benefits far outweigh the risks, especially if have had your ovaries taken out. The risks of heart disease, bone disease, those far outweigh, you know, any risks of taking hormone therapy. So I think it's important, again, to make sure that where you're getting your information is
Mm,
accurate, because there's still a lot of fear that may breed, these myths. And it, it's so important to find somebody who has done the extra legwork of finding out what are the current guidelines, what is the current information.
yeah.
And the Menopause Society provides a lot of that in some position statements. So even just digging up the Menopause Society, looking on their website and looking at what the current position statements are, is also one way to take those, that information to your doctor, or, nurse practitioner or PCP, to find out, hey, can you look at this with me?
Terrific. Thank you so much for that. Our next myth, I'd like to preface with a story. And I hope you'll bear with me. This is a nightmare. I
Yeah.
have a friend who several years ago, she was in her mid 40s, I believe, at the time. She was still menstruating. She was in perimenopause. Did not know it. Nobody was talking about it. This was, at least 10 years ago.
Mm-hmm.
And she asked me to take her to the hospital for something. And I did. And she was told by the nurse that she needed a pregnancy test.
Yeah.
Fine. And she said, "Oh, well, I'm sure I'm not pregnant." She was sexually active, and I said, "Okay, hope you've been using protection. We don't want like a horrible surprise right now." This is the second part of the story. The nurse who was caring for her came in the room and very seriously put his hands together, and he said, "I have to tell you, you're pregnant." And we both gasped. She started crying and he said, "I'm just kidding." And I lost it, which was, that is truly the, yeah, it was horrible. I lost my mind. I was so angry. But so that's another issue. But she didn't realize that she could still get pregnant anymore. And so myth number 7 or 6 is you cannot get pregnant in perimenopause.
So that is absolutely not true. You I've had patients who, 47, spontaneously pregnant, and they were like, "Oh, I just didn't think I could get pregnant," and so weren't using protection. So I think it's very important to realize that just because you're in perimenopause does not mean that your fertility. Obviously, your fertility declines with age, right? We all know that fertility declines with age, and when you start having some of the symptoms of of menopause, and you're still having periods, the chances of like regular ovulation again decline the closer you get, the later you get in perimenopause, but it's still not impossible to conceive. So it is important, if you're going to use hormone therapy, menopause hormone therapy versus a low dose birth control pill, to help with your symptoms, you're going to need to also consider that you need to think about how you can avoid getting pregnant while you're on hormone therapy, because hormone therapy will help with symptoms, but not a high enough dose to reduce your chances of getting pregnant. So it's very important. Like for some women who are in perimenopause, whether it's early or late perimenopause, they elect to stay on the low dose birth control pill. And we offer that not as, as even OBGYNs, we offer it not because we don't want to give hormone therapy, but it's because it's so important to make sure that, number one, if you need contraception, and you're not electing to go with like an IUD or some other form of contraception, the low dose birth control pill still does provide estradiol, but it provides enough that it'll, suppress, ovulation. So
Okay.
you're not, the chances of ovulating are slim
Okay.
to none.
Okay, great. Thank you. Weight gain is inevitable and uncontrollable.
Okay. So some of the hormonal fluctuations make it easier, to gain weight. It does not necessarily mean that it's going to happen, but it just makes it easier. And it's so important to attend to like things like nutrition, exercise, um, you know, and nutrition just doesn't mean going on a diet. It really means paying attention to what you are eating. So like looking at like as get into as you enter perimenopause and menopause, like what is your fiber, like what is your protein, what is the amount of fiber and protein in your diet, are there a lot of like like vegetables, fruits, those types of things, to really make sure that you are not consuming what's just going to cause that mid abdominal weight gain. So again, it's not inevitable. However, hormonal fluctuations can contribute to making it easier to gain weight. So it's just
Okay.
pay attention to some of your lifestyle modifications, like if you consume a lot of alcohol, maybe cutting back on that. Like there are just different things you can do to avoid it.
And in terms of exercise, what are your thoughts on this?
Uh,
And weight gain, exercise.
I mean, I think nutrition plays a huge, like what it is that plays a huge role. I think the exercise is important when it comes to muscle mass. You start losing muscle mass when you go through the hormonal transition. So it's important that with protein, and the exercise that you're doing is resistance exercise. Like Pilates is really good. I talk to my patients about Pilates because it's going to contribute to bone strength.
Okay.
So the bone and muscle is so important when you enter this hormonal transition.
Okay, but nutrition specifically speaks really loudly to you and should be to us.
Yeah,
Yeah.
absolutely.
Okay.
Exercise is great. I mean, making sure you're moving your body, right? Going on walks, cardio. I still tell my patients continue to do cardio. It's not, that, but I also want to make sure that the resistance exercise, and weights is, if you're not doing weights like Pilates, like some type of resistance, even if it's your own body, full body resistance. Like my trainers always Kudzai whether or not we're using weights, it's like we need to do some form of
Okay.
resistance. So important, as we get older.
Thank you. Dr. Dombo, only women with severe symptoms need menopause hormonal therapy. Can you talk about that myth?
For sure. So um, that was something, again, when the WHI came out, that study, what tended to occur after that was, okay, well, we'll look at trying to be very conservative. If you're having bothersome symptoms, use like, black cohosh and soy and all these other, if it's really, really bothersome, then we'll treat you. And I think, again, that looks at, a kind of patriarchal society where we're meant to suffer. And I don't think we're meant to suffer in life. If you just want to feel good, you want to feel your best, there's nothing wrong with that. And even if you're not having hot flashes or night, but you are having some of the other symptoms. Like I know for me, it was the debilitating fatigue, and
Yeah.
it was the right that just kept me on the couch, and it impacted my ability to like delivering babies and running to the hospital. Like I just felt like it was so difficult to function because when I wasn't working, I was just laying on the couch because I was just so tired and my mood was just, and I couldn't sleep. So, but to say that, oh, because I wasn't having necessarily crazy hot flashes,
Right.
therefore I don't treatment, I think it's just not fair, because for some women it may, show up as, oh my gosh, my joint, my body, my muscles, like it's just like my body is not myself. And that can be
Yeah.
distressing, right?
Sure.
And so I think just to qualify treatment based on flashes and night sweats, I think it just does a disservice to us as women
Yeah.
because I think we have so much to offer. And when we can't function, um, as our best selves, like it impacts so many other, it impacts our work, it impacts our families, it impacts so many different aspects
Right.
of our.
And I think it's so important to remember that what is not tolerable for you may not be so for somebody else, right? Everyone, although there are these sort of agreed upon symptoms, or there's this common thread uh, among the population going through
Yep.
it. Oh, yes, I had that. Oh, yes, I had that. What is debilitating to you may not be so for someone, but
Yeah.
the solution may be the same. Is that fair?
That's fair to say because I think again when we're looking at what is it that we're going to treat, right, there are guidelines that as doctors we know, okay, what are the guidelines, but I think those guidelines are to help us, and I think each person is unique.
Right.
Guidelines, but I'm saying each person is unique in the amount of suffering, right, they experience. And I think it's important to take that into account and really listen to, okay, because I had another patient who, she was just like, I'm going to be on set and I cannot have any bleeding. I can't be running to my trailer.
Right. Right. Okay.
And so looking at for her with, the
Mm,
things that did, that was so important. So when we came to looking at a plan, it was like, okay, so let's take a look at what alleviate this concern, but then it's also going to help over here. So that's where I think every person is unique. Everybody's an individual. And so important, I think, to meet women where we are because we all have big lives and we're
yeah.
all trying to accomplish, a lot of different things. And even if it's just being the best mom, right, to my, to children, like, there's something about us that it shouldn't be broken down to if you have X, Y, and Z, then you weren't. It's like
Yeah.
really how distressed, what level of distress is causing you?
Yeah. Thank you. Um, this is one that I came across and I was actually surprised, and it made me wonder if this was sort of the education of physicians some time ago. There's this myth out there that you no longer need to care for sort of your feminine health concerns. So, um, was it ever out there that once you were in menopause, you no longer needed to get a pap smear, for example?
You know, I think again, this goes to a lot of the focus of where, our education went. And it's interesting because I do see a lot of patients who come in and they're like, oh, well, my last pap smear was right after my kids. And this is like 20 years old,
Wow.
right? My smear, the last time I had a pap, I mean, it was normal, but it was after my last child, right? And so I think there has been such a huge focus on
Yes,
reproductive,
yes.
assessment, and gynecological disorders that occur. Um, so looking at, okay, we know that we're supposed to get our mammogram. And now like with some of the guidelines, they're saying 5 years, if you've had normal pap smears. I think the important part of how do we take care of women during this stage is where what we're trying to figure out now,
Mm,
right? Because I think, again, the focus, especially with our training, has been pregnancy, postpartum, and then gynecological conditions that may occur like in your 40s and your 50s. And then we're dealing with either cancers or, some of those more complex issues that, we refer out. So I think women have just followed that trajectory. Okay, I'm important, when I'm, in my
right.
childbearing years. And then after that, like, I don't really need to go see the doctor anymore, which, is just not.
It's just not true. So tell us what is true. So in perimenopause, menopause, how often should we be going for screenings? What kind of screenings should we be getting?
Yeah. Well, I think it's really important. I personally think it's important to still be seen, even if you don't need your pap smear at least minimum, like at least once a year, right? By your OBGYN, your primary, because the thing is in perimenopause, like your triglyceride, your cholesterol level may change,
Right.
you may be diabetic. And I think those things are so important to pay attention to because, and I think, and this is where I get, aggravated because I do sometimes see patients who come in and they're like, oh, my doctor's normal. And they're point shy of being pre-diabetic. So
Mm,
then they're going to come back next year and you're going to be pre-diabetic and then they're going to offer you medication. No, we need to come up with a plan now,
yeah.
right? Of navigate getting you so that you're not anywhere close to being pre-diabetic. So I think it's just important that when you do go see your primary care doctor, OBGYN, you know, or you're seeing somebody who really considers it really important during that midlife time, like you're going over those symptoms that we talked about. Hey,
Yeah.
I've noticed, my periods are getting shorter, or hey, I've noticed that, these symptoms are getting more during this time. So I think, again, in addition to cervical cancer screening, mammogram, colonoscopy age 45, those are all important benchmarks. But I still think it's important to make sure that your lipid profile is good. Let's take a look at, screening for diabetes and prediabetes. Let's take a look and make sure that your liver function is, because again, perimenopause, menopause, you can be more prone to getting fat, fatty liver, so there are all these things that, just are important to identify because, they may impact your ability to be on hormone replacement, hormone therapy.
Okay.
So it's important.
So I'm going to bring you back just 30 seconds because you were cutting out a little bit. And I think this is important. I agree that. So the next myth, if you will, is that getting your levels tested to see if you're in perimenopause is something valid and worth doing. I'm
Yeah.
going to give you a second to talk about why this is not so, but then also just for sake of hearing, what should we be getting tested for and what can be confusing? Because, for example, thyroid issues can look a lot like perimenopause. So, how do we know what we should be asking to be tested for?
Right. So, okay, starting with your question about with hormones, why should we not get tested, right? Because it's a myth that, oh, you should get your hormones be tested, but that's not true. Because during perimenopause, and this is, I liken it to, when you just aren't feeling good, it
Mhm.
that, oh, your labs are normal, your hormones are normal. And a lot of women are like, there's a disconnect between how I'm feeling and what my blood work is showing. And the reason why is because when you are going through perimenopause, you have these wild fluctuations of your hormones. So in the morning, you can be at your estradiol can be low. That evening, it can be high. So let's say you're getting blood tested in the afternoon, it'll show up as normal. So it's the fluctuations aren't really going to give us a solid idea of what's happening in your body. So the number doesn't reflect the symptom. And that's why it's so important that we actually sit down and go through your symptoms to see, okay, what are the symptoms that are the most bothersome? What are symptoms that are more tolerable? And what are symptoms that, they may be somewhat bothersome, but I'm not too worried about them. So it's important that we take a look at that spectrum of symptoms because that'll help us guide the appropriate therapy for you, looking at your medical history, your family history. We can determine what formulation is best for you. And we take it from there. It's not linear. So when you look at like the example I gave for prediabetes, right? So we know the cutoff number, therefore we know what to do,
Mm,
right? So the cutoff number, we know what to do. Some doctors are like, okay, you start metformin when you have this number. It's not like that with your hormones, at least estradiol, progesterone, testosterone, right? I mean, testosterone a little bit more so, but even with testosterone, you can have a normal number and feel crappy inside. I'm talking about even low, and that just doesn't mean that, oh, you're not a candidate. It just means that, okay, let's take a look at everything and determine where we're going to start you at, maybe what dose, and see if you notice a difference. So again, going back to what you said, the reason why we don't test hormone levels is because we really base our treatment on symptoms. And getting you to feel better is really the goal if your symptoms are a result of these hormonal fluctuations or hormonal declines,
got
right?
it. Okay.
And so then when you do go to your doctor, so this is the second, what types of things should I get tested for? Definitely important to get, like a blood count, because if you're perimenopausal and you're having really heavy bleeding, are you anemic? Is that what's
Mhm.
contributing to your fatigue? Right? That could be one reason. So, when we're looking at the full picture, I want to know, if you're anemic. So that's important. So we do a CBC. You do a complete metabolic panel, which includes your kidney function, your liver function, your electrolytes. And again, your liver function is important because at the end of the day, when your hormones are excreted by your body, the liver is responsible for breaking them down. So it's important to know that function is normal. And then the other important thing is, again, as I said, a lipid profile. That's important just to see where you are. The other thing that's important, oh, and so with your complete metabolic panel comes screening for diabetes if you're fasting, because we know what your fasting blood sugar should be. You can have a more, extensive diabetes test or screen, which is a 1 hour glucose test, tolerance test. So that's another, test that you could do for diabetes. So that's important to get done as well. And depending on if you're in menopause, you also take a look and see if there's inflammation in your body, because a lot of times when production goes down, inflammation goes up. So you can look at a C-reactive protein, you can look at an ESR. Those are levels that can tell us, give us an idea as to whether or not there's like extensive inflammation going on within your body.
So
Because,
helpful.
you know, maybe that's the reason why it's really hard to lose the weight. And then
Yes,
we have,
that's so
yeah,
helpful. Thank you. Thank you so much for that. We're getting close to we have 6 minutes left,
yeah,
but another myth. Estrogen is all you need for symptom management.
yes, that is absolutely not true. So estrogen plays a huge part in a lot of the symptoms that come with perimenopause and menopause, but it's not the only hormone. So the ovary produces so a lot of different hormones, right? The ovary produces multiple, but there are three main ones, that the ovary produces, and that's estradiol, or 17 beta hydroxyestradiol. There's progesterone, and there's also testosterone. So, when your levels start to change, you're going to need to replace, those hormones. It's more controversial with testosterone because that is one of the hormones that actually you need to get a lab test to see where you are. And then even after you start testosterone supplementation, it's important to kind of see after 3 months what has been going on with your body, because your levels can, depending on how you, either it's absorbed as a cream or you use it as a gel or an injection, there are different ways that your body can process it. So it's important to test that level. But when it comes to the estradiol and the progesterone obviously is helpful to protect the uterine lining from overgrowth that can be caused by estrogen. It's also beneficial because oral micronized bioidentical progesterone also
Helps with
sleep.
sleep.
Yes.
Yes, I can
So
attest to this.
yeah. So that's where, even if you've had a hysterectomy, I've had several patients who've had a hysterectomy, they don't need the progesterone, but they elect to go to keep to add that to their regimen because progesterone is so beneficial in helping with sleep.
Yeah.
So so those are the three hormones that estrogen and progesterone, definitely, used together. And then, also supplementing with testosterone is an option as well.
Dr. Dombo, I see somebody commented here, and I would love for you to weigh in on this. She said, I had the Dutch test done with
Mhm.
26 vials of blood to check my stress hormones and sex hormones. I'm definitely in perimenopause. I have a gazillion symptoms, just don't know which to choose. I don't know if she means in terms of symptom management, which to choose. I'm going to assume so, but can you speak to that and also tell us a little bit about the Dutch test?
Yeah. So the Dutch test I know is done in more functional medicine spaces, more integrative medicine spaces. And I think it just goes back to where you can have these tests, blood work done. But at the end of the day, I'm going to listen to what your symptoms are.
Yeah.
I don't hear that, but I'm going to listen to what your symptoms are and then look at how can we alleviate some of those symptoms. Because I already know, if you're in perimenopause, and I don't know how old you are, but if you're in perimenopause and having symptoms, the goal for me is for you to have at least a 70% improvement in your symptoms. Okay. That's what I'm shooting for is 70 to 80% improvement in symptoms. I never shoot for 100% because 100% you're going to start getting into the side effects and dealing with having to navigate that. So it's balancing the benefits with avoiding some of the side effects. So if you're in perimenopause and you're having symptoms, had testing done, that's fine. But again, I direct, and most I know menopause specialists direct treatment based on your symptoms versus the results of a test. Because you can feel completely normal and have abnormal results, or you could feel horrible and have normal results.
Yeah. Yeah.
Yeah. Or you could fall somewhere in between. And so, again, the American College of Obstetrics and Gynecology, the North American Menopause Society, they all say really let's kind of try to focus on symptoms.
Okay, thank you for that. That's super helpful, and I think helpful to hear probably more often.
Mhm.
Someone else asks, how long is hormone replacement used? Is it just until you stop menstruating, or is it used much longer? I love this question. Thank
Yeah.
you.
And it's such a personalized thing because symptoms can last 10 years before that last menstrual period, and they can go on 10 years past that last menstrual period, right?
Mhm.
I have some patients in their late 60s, early 70s, and they are like, my doctor shut down their practice and I'm on estrogen for, you know, however many years. And I stopped because my doctor, I can't find anybody to prescribe it for me anymore. Really bad symptoms. So again, it's not, there's no definite point unless you start to develop um, certain medical conditions that preclude you from being able to be on hormone therapy. Like let's say you have, acute liver disease or active liver disease,
Right.
you know, had certain conditions that make it unsafe for us to now continue you, then that's where we say, okay, we need to kind of wean you off. Or let's say you've been on it for 5 years and you don't want it to be on it for longer than that. And again, 5 years is not the magical number. It's just they've determined it's the average number of years that women have chosen to stay on it in the past. But you can try to see if weaning yourself off at that point, if you want to do, you can do that. But if your symptoms come back,
Yeah.
there's no need to feel like, oh my gosh, I can't be on it for longer. As long as it's helping, as long as contra indications, then absolutely, like you can be on for as long as you want. And that's why I love my 70-year-old patients, because, they really like, look, I do not want to go off. And my doctor told me I have to go off at 65. And after a deep dive into their medical history and other things, it's like
Why
there's
not?
no reason.
I you remind me of after when the sort of hullabaloo around the WHI, the revisiting of the WHI that happened, and I started to hear stories from doctors and patients who were recommended to come off of menopause hormonal
Yeah.
treatment at the conclusion of the WHI,
Yeah.
and they sort of secretly asked their doctors to keep prescribing, or they found a doctor who would continue to prescribe. And these were women who were in their 60s. These were women whose lives were disrupted by the symptoms of perimenopause and menopause, found relief with hormone replacement or menopause hormonal treatment, and had no, there was like, I am not stopping this thing, I am not stopping this train. And we're sort of like quietly underground getting relief.
Yeah.
But I think that speaks to, again, just how um effective menopause hormonal treatment
Yeah.
is.
I have one patient, she was actually in the WHI study.
Oh,
Okay.
you're kidding.
Yeah, yeah, she was in the WHI study, and so she obviously, like, everybody in the study, it was stopped during 2002, and so she came to me, and I believe she's 80, in her 80s now, and again, she wasn't interested in systemic because she wasn't anymore, but she was having recurrent UTIs. She was just
Mm,
so thankful, and she thought it was revolutionary, for me to prescribe her vaginal estrogen, because
wow.
he had been literally like told after that no, you can't, like, estrogen's not good. And so she, of course, having been in the study itself, felt like, I just can't go on this anymore. So it was really great to be able to really just go through everything with her, talk to her about the pros, the cons, the benefits. And she was so grateful, so grateful on
Dr.
vaginal estrogen.
Dombo, I'm sorry I interrupted.
No.
Thank you for that story. I didn't plan to ask you this, but you just made me think about a woman who's considering, seeking out sort of the most effective relief for her
uh,
symptoms. She's come to us new. She's watching your educate us, listening to us educate, listening to you educate all of us. What happens when we connect with you on
yeah.
the Alloy platform? How does that go?
So basically what happens is, as a physician, as a patient, you'll fill out, an intake form. I'm not sure, again, all the details on that side, but once you fill it out, it comes to you, one of the Alloy doctors, their queue, and, we able to open it. We review everything. We look at age. We look at, just all your medications. We look at your history. We look at your menstrual history, your family history. We look at the last time you saw a gynecologist, if you're having, irregular periods, if your gynecologist has evaluated anything, and if not, that's, it's just a long detail of information that is almost absolutely everything that we need to know. And then if there are things that show up in that history that we're not clear on, and this happens quite, times where I'm like, oh, you were on previous, hormone therapy. Um, you're happy with it. Do you want to stay on the same dose? Like, we
Mhm.
have like I guess a chat.
Yeah,
Um,
an email
yeah,
discourse, if you will. Yeah.
and it's been pretty effective, in being able to get the information that's important for us as Alloy, prescribing physicians. Um, and so if there are any questions, we're able to answer them. And then we come up with a treatment plan with options. Again, we love to be able to give you options that are the safest for you. So it's not going to be just necessarily one thing, unless you have contraindications, clearly. There may be just one or two things that you may be a candidate for, but for the most part, we try to give you as many options as possible. We go over the pluses and the minuses of some of the different ones, and then it's in your treatment plan. It's in your dashboard for you to choose, and then you can select what you want, and then you can check out. And then at any point, you can message me back and forth, if you have any questions, even after the prescriptions are prescribed. And that's the beauty, is that we're there to kind of hold your hand through the process, um,
Mm.
for as long as you have active prescriptions through Alloy. So, there are times where I get patients, who are like, you know, I'm on vacation and I lost my prescription. What do I do? And we kind of try to get them in touch with support. Or, there may be like, oh my gosh, I noticed some spotting and I'm really concerned. What do I do? And then we're able to kind of respond to that. Or if you feel like, oh my gosh, I took the progesterone and I'm really nauseous, or
Mm.
I'm having some and it's just not agreeing with me, then we can look at, okay, let's try a different route. Let's try the progesterone vaginally. And then if the progesterone isn't working for you vaginally, then we can talk about another form. So it's this, like, I feel like starting, on the journey is what I call it, the journey of, being on hormone therapy. It's not just oh, check and, we set you prescriptions and you're done. It's like we're there for you along the
Yeah.
way. It's like we're there. Like it's not like, here, you're done.
Yeah,
You
here, take your script. See you later.
see you
I
later.
I so appreciate that, and I again, I didn't anticipate asking you that. Something you said made me think of it, and more than anything, the thread in this conversation is again about your need versus your need versus your need,
Yeah.
the nuances of menopause care. um, it's not that it's complicated necessarily for a practitioner who's well versed in menopause treatment, but given each one of our individual needs, it could need a little tweak here, a little extended conversation there to sort of get us to the right place. But it certainly is possible, and there is no reason to kind of muscle your way through suffering.
Or even this, or like there's no reason for you to hear misinformation or hear information that you're not sure about and then not be able to have anywhere to go,
That's yes.
verify, or because what I love to do is say, okay, I'm going to send you an article, or and this is what I love about just being a group, right? Because we're like, we have different people who can be like, okay, here's an article on this, or if there's a more complicated patient presentation, we can weigh in with some of our other more seasoned, right, like Dr. Malone, like they're just a tap away,
Yes.
because
Yes.
actually say, okay, we have advisors. We put, like Dr. Michelle Montville, Dr. Corinne Menn, like they're people who, even if I don't know the answer,
Right.
right, I'm not just going to put a block and be like, because I don't know, it's a no.
Yeah, it's a no.
What
Right.
I love
That's just
is
not
that
so.
a group of us, right? And so if I don't know, I'm going to go and find out, from, someone else, like, hey, have you encountered this? Have you seen this? How can we support this patient? Or, if not providing that service right now, how do we what are the resources that I can offer,
Yeah.
this person, so that they can seek, the care that they need. So that's what
Which
I
all which all is about, best health outcomes for women, being in real service to women. I'm so appreciative of that. I This is totally off topic, but someone also said, the person who asked you a question earlier says that she uses M4 for her face and it's incredible. So I bring that up to say awesome. I'm so glad you're loving it. And also that we are going to be talking again with Dr. Dombo about a whole bunch of things, but I'm also hoping that we'll get to speak with her more about our M4 and other things coming down the pike in time. Um, we covered a lot of myths today. Thank you for debunking them, Dr. Dombo.
um
Thank you all for being here. It's always a pleasure to speak with you and learn from you. Carry on, ladies. Do not suffer in silence.
yeah.
Take note of your symptoms. Bring them to a menopause specialist.
Yep.
Get the help you need. Anything else you want to leave us with?
I think it's just important that, again, like, we're able to identify what our fears are, but let's get to the root cause of it so that we can actually operate with freedom, right?
Mm,
Because I think sometimes I see patients who hear things or see things and they're not sure about it, and then feels a lot of fear. But it's important to voice or get in touch with, okay, what is it that's making me afraid, right? What is
yeah.
it that I'm afraid? of doing this. And it's okay to be afraid. It's not like anything to be condemned, but just take it to somebody who you trust, who's a
Mm.
safe space. And I think, I what I appreciate about Alloy is that there is, for me, that I feel like if I was a patient, I would feel
Yes.
comfortable to the physician,
Yes.
because I think we are encouraged to reach out if we don't know the answer.
Thank you for that. We have a deep well here at Alloy Women's Health. Thank you so much, Dr. Dombo.
Um,
We will see you next month for our webinar. Be on the lookout for it, everybody.
yes,
Register for it,
yes,
and we will keep
sounds
talking.
good.
Okay,
Thanks, Rachel.
thanks. Bye, everyone.